Dear colleagues, today I will present a case of a fetus affected by multiple cysts, depletion of the Blake's pouch cyst, and a right-sided aberrant subclavian artery. The patient came to our attention at 21 weeks and 0 days due to the finding of ventriculomegaly on the second trimester screening ultrasound. At first glance, it might seem that the simple finding of borderline ventriculomegaly reported in the second trimester screening exam is confirmed, but with closer observation, one realizes the presence of multiple cysts within the choroid plexuses, which, as they increase in size, create a false image of ventriculomegaly. As you can see in these clips, in the coronal section, the picture appears very clear, and it is possible to measure the cysts bilaterally. It should be remembered that choroid plexus cysts are cystic formations filled with fluid. They are present in 1 out of every 50 fetuses at the 20th week of pregnancy, but in more than 90% of cases, they resolve spontaneously by the 26th week. They can be a benign finding, however, they are associated with an increased risk of trisomy 18, and their detection requires a detailed ultrasound examination to rule out the presence of other anomalies. Therefore, a detailed neurosonographic study is performed, as well as an evaluation of the cranial fossa after trauma. We can observe the presence of a Blake's pouch cyst. This is an expansion of the fourth ventricle into the cisterna magna, resulting in a unilocular and a vascular cyst in the posterior cranial fossa. It has a prevalence of 1 in 1,000 births, and this too, like the previous one, can be a completely benign finding, especially when isolated. However, its detection requires a detailed ultrasound examination specifically to look for the presence of other anomalies. And when these are present, further investigation is necessary, including genetic counseling and, if needed, invasive amniotic testing. The rest of the fetal neurosonography is normal, with regular cranial biometry, presence of the cavum septi pellucidum, opercularization of the insula, and direct visualization of the corpus callosum. We then proceed with the study of the cardiac anatomy, which is normal. The 4 chambers are normal, both the first and second septa are present, as you can see. The right and left flows are normal. At the time of the scan, in the 3-vessel trachea view, it is observed with color Doppler imaging, a vessel originating from the aortic arch and crossing the chest with a retrotracheal course heading to the right. This is a right aberrant subclavian artery, which is the most common anomaly of the aortic arch, constituting an anatomical variant in 1 to 1.5% of the healthy population. Nevertheless, it is considered a soft marker. Therefore, its detection requires a detailed ultrasound examination and an echocardiogram to rule out the presence of other anomalies. The presence of the thymus is also assessed, and its hyperplasia is ruled out, taking its measurements by identifying the artery. This is done using color Doppler imaging. The echocardiographic examination is completed, and as an additional finding, a marked levocardia is noted. The management of the case includes a prenatal genetic consultation, an invasive diagnostic test with karyotype evaluation, and possibly also RCH, a pediatric cardiology consultation, and obstetric monitoring with ultrasound follow-up every 4 weeks. Thank you for your attention.